Excellent. Hi, this is Katie Smith. I'm an associate professor at the University of Oklahoma in the Department of OBGYN. I also am the director of our dysplasia and lower genital tract disease clinic, where we see referrals from all over the state for precancerous conditions of the cervix, vagina, and vulva. And today I'm going to update you in cervical cancer screening, and hopefully I'll take away some good information that you can put into practice as you screen patients throughout the state. Our objectives for today, we're going to describe cervical cancer screening options for immunocompetent women in each group, and then discuss ways, referral and follow-up options for those women who you screen who have cytologic abnormalities. Today I'll be utilizing the consensus guidelines from the ASCCP, and those are available in print form from their website or online. So we begin screening at age 21 for immunocompetent women. So these are women who don't have 3 years with cytology alone. So this is just a Pap test. There's no HPV screening indicated in this age group because for low-grade abnormalities such as LSIL or ASCUS, we're going to repeat their cytology in 12 months. If we do HPV screening, the recommendations don't change. So an LSIL or ASCUS that's HPV positive in a 21 to 24-year-old is still going to get repeat cytology in 12 months or a repeat PAP in a year. So doing high-risk HPV screening increases the cost for this age group and doesn't change the management, so it's not recommended. Patients who have LSIL and ASCUS PAP in the 21 to 24-year-old age group, they're going to, we're going to plan to have their PAP repeated in 12 months, and if they're still abnormal, then you would refer them out for colposcopy. If the patient has any high-grade changes, so AGC PAPs, ASC-H, or HSIL, those patients should be referred to colposcopy as soon as you get that PAP test result. Next, we'll move to screening guidelines for age 25 to 29. This age group has the highest risk of finding precancerous cells or high-grade dysplasia. That's because many of them who have carried HPV for the last 10 years or so are going to start showing those precancerous changes. So for these patients, we're still going to screen them with a PAP every 3 years, but we want to know if their ASCUS PAP is HPV positive or negative. An HPV negative PAP test in this age group is going to be managed differently than HPV positive. So ASCUS HPV positive or any other abnormality such as LSIL, ASC-H, HSIL, or AGC is going to result in colposcopy referral. For ASCUS HPV negative, that patient is going to come back in 3 years, so routine screening for that age group. So ASCUS HPV negative carries the same or a similar 5-year risk of high-grade dysplasia as a normal PAP does. That's around 0.5%. So because that risk is so low, then 3-year follow-up is recommended. So for patients who are at a 5% or higher 5-year risk, they're going to go for colposcopy. If they're between about 2 and 5, then that means we're going to screen them again in a year. And then under 2%, it's either going to be 3-year or 5-year return. So this is all based on the patient's risk of high-grade dysplasia. So that ASCUS HPV negative, again, that's about a 0.5% risk over 5 years of developing precancerous cells. so they can come back in 3 years. Once a woman reaches the age of 30, you may continue to screen with a Pap test or cytology alone every 3 years. That is acceptable. But the preferred method of screening is co-testing every 5 years. Co-testing is a better test. That's ordering a Pap and HPV test simultaneously. So you would get a Pap result and then a high-risk HPV positive or negative result. Our guidelines use not acceptable, acceptable, and preferred language. And so anytime you see something that's not acceptable, you shouldn't be doing it. And acceptable is just what it says, but the preferred is the preferred management based on all the evidence available. So in an ideal setting, if these patients are being screened, that means they're not coming back after having an abnormality, they don't have a history of dysplasia, they can be screened with a cytology and HPV test every 5 years, so long as they remain normal Pap HPV negative. And that's the best way to screen in this age group. What happens in this age group if you have a normal Pap and your high-risk HPV test is positive? Well, you have two options. You can repeat their Pap and HPV in 12 months, or you can do an HPV 16-18 triage. So essentially, once the lab gets that positive test, you can ask them to run a test that will tell you if the patient is HPV 16 positive, HPV 18 positive, or high-risk other positive. If the patient has either 16 or 18, then they need to come to colposcopy. If they're other positive, then they're going to bring them back in a year and repeat their co-testing. If they come back in a year and they have any abnormality, HPV positive no matter what type, or any cytologic abnormality, ASCUS, L-cell, H-cell, for example, then they will come to colposcopy. What about if you have unsatisfactory cytology? We see this less often, but sometimes in patients who have different medical conditions, depending on their age, different factors, we can get an unsatisfactory cytology. Essentially, we haven't collected enough cells for our lab to give us a result on whether those cells are normal or abnormal. The big thing here is you have several options. If your HPV is negative or unknown, then repeat the cytology in 2 to 4 months. You don't have to repeat the HPV test. So if you bring them back in 3 months and their Pap is normal and their HPV before was negative, fantastic. You can screen them again at a routine interval. If the HPV is positive, you can refer to colposcopy because you would be coming to colposcopy for anything except normal, and you could consider colposcopy if their Pap was normal and HPV is positive. Or you can bring them back in 2 to 4 months and repeat their cytology. And then once you have that Pap result, then decide what to do with that Pap plus HPV positive. If you bring them back for any reason and you repeat the cytology and it's unsatisfactory again, then we abandon doing more screening and we bring them to colposcopy to find out why we aren't collecting enough cells, what's happening on that cervix that's not allowing us to get a result on our Pap, whether that's inflammation or some sort of disease process otherwise. Let's say you get a normal Pap, but your result tells you that there's an absence of endocellular or endocervical component, or that the transformation zone is absent. If this patient is below the age of 30, then it's routine screening. This doesn't change your management. So if you have, say, a 25-year-old who has a normal Pap, endocervical transformation zone absent, you're going to bring them back in 3 years, just as you would for any other 25-year-old with a normal Pap. For age 30, if their HPV is negative and their Pap is normal, you continue routine screening even if there's absence of the endocervical component. HPV positive is managed exactly the same. In this case, really the difference is the HPV testing. So if you're screening women over the age of 30 with cytology alone, so you're only getting Pap tests, and you're not getting endocervical or transformation zone, because of that increased risk of missing disease, it is preferred to have an HPV test, just because we know that HPV has higher sensitivity and is actually very good for picking up endocervical disease that Pap may miss. So if you have absent endocervical component, the preferred management, if you haven't done so, is HPV testing, and then using that HPV test to manage your patient. When do you stop? Currently, guidelines say stop at the age of 65. If a woman has had a hysterectomy for benign disease, no history of dysplasia, cancer, no history of Leaps, cones, anything like that, when they turn 65 or when they have their hysterectomy with removal of their cervix, they can be done with screening. So if you see a woman who's in her 50s and she's had her uterus removed for fibroids, and she endorses that she got her routine Pap test, she came every year or every 3 years, and they were all normal, she doesn't need to continue screening. If you have a patient with that same history but has a uterus, a 65-year-old who says, you know, I got my Pap every time my doctor told me to, it was always normal, and here I am at 65, then you may stop screening. The big problem here is if you don't have enough information. So many times patients don't stay in the same system. They're being screened with different doctors in different states or locations. So a lot of times patients will come to us and we won't know their screening history, or they won't have had a Pap in 5 years or 10 years because of access to health care. And so we never recommend stopping screening unless you know the patient has been adequately screened in the past and you have information about that screening. So if I see a 65-year-old and she hasn't had a Pap in the last 5 years, I'm going to recommend co-testing for her. And then depending on what her history is, I may continue to screen her for, again, in 5 years, to make sure that she has 10 years of documented normal Pap HPV negative. If the patient comes, she's been my patient for the last 15 or 20 years, she's had appropriate cervical cancer screening, it's all been negative, she has no history of dysplasia. When she turns 65, we can be done screening. Now, patients who have a history of LEEP or cold knife cone for high-grade dysplasia, they need to be screened for at least 20 years following their procedure. If the procedure was done early in life, say it was done in their 20s, they had 20 years of follow-up into their 40s, that was normal, they continued follow-up up until age 65 and everything has been normal, then they can discontinue screening. They've had enough follow-up from their excision and they've had adequate screening. Again, any patient who you don't know their history, you're not sure if they've had any disease, or if they haven't been appropriately or adequately screened, especially in the last 10 years, you'll want to go ahead and do their Pap screening. What about primary HPV screening? So this is not something that we routinely do or is done very much in this region of the country, but it is acceptable. We know that, so what primary HPV screening does is you're going to collect your Pap in the same way, but you're going to run an HPV test first. If the HPV is negative, then you're done. If the HPV is positive, then we'll want to know what the cytology is and is the patient 16 or 18 positive and manage from there. So essentially, you are kind of triaging using your HPV test and going backwards to cytology. Because it does utilize an HPV test, we know it's more effective than cytology alone. We don't do HPV testing prior to the age of 25, so it's not recommended for those patients. It's at least as effective as co-testing. So right now, co-testing and primary HPV screening are thought to be fairly equivalent. So if you're doing co-testing, you could switch to this, although most of us are have adopted co-testing and is working well. So right now, there's no recommendation to switch to primary HPV screening for any reason other than preference. What about pregnant patients? So screening in pregnancy, we follow the same screening guidelines. So a pregnant woman under the age of 21 would not need to be screened. And then at 21 and over, you would screen per their normal age group guidelines. So if they had a PAP a year ago and they're age 25, that was normal, no history of abnormality, then they need to be screened again in 3 years. So that if their pregnancy occurred a year later, they wouldn't necessarily need to be screened. If a patient is due for a PAP and it's done in pregnancy, then you have some options. ASCUS and LSIL are going to go to colposcopy or during the pregnancy, but can wait until 6 weeks postpartum. So you see that preferred and acceptable there again. So going to colposcopy during pregnancy is preferred, but for these low grade cytologic abnormalities, they can follow up postpartum instead if the patient desires. For a discordant co-test, so that's a normal PAP, HPV positive, you're going to repeat their PAP in 12 months or triage them with 16-18 testing, which they would come to colposcopy if that was positive. For any AGC, ASK-H, H-cell abnormalities, those patients should be referred to colposcopy or managed as indicated for the age group. So we can do colposcopy in pregnancy. Biopsies are very safe. Endocervical curettage is contraindicated in pregnancy, so we never perform those. And under most circumstances would not recommend any excisional procedure in pregnancy. But like I said, we can perform biopsies, find out information, and plan for treatment postpartum if necessary. Atypical glandular cells. So this can be one of the most confusing areas because sometimes you'll see AGUS, sometimes you'll see AGC. So the reports you get back on AGC PAPs may look very different depending on the lab you're using or the cytopathologist. The short story is that all AGC PAP tests should be referred for colposcopy. So atypical, there's subcategories. Atypical favor endometrial, atypical favor endocervical, atypical not otherwise specified, and atypical favor neoplasia. So atypical endometrial cells, they do not necessarily need a colposcopy. They can be managed with endocervical and endometrial sampling. So many times providers will be referring those patients to us, not necessarily because they need a colposcopy, but we need to do the endocervical and endometrial curettage in the office. If we don't find anything there, then we're going to go to colposcopy. Endometrial sampling with an endometrial biopsy should be done for anyone with an AGC PAP who's over 35 or has risk factors such as obesity, diabetes, anovulatory disorders, hypertension, anything that puts them at risk for endometrial hyperplasia. Of course, atypical endocervical cells, AGC NOS, and AGC favor neoplasia needs to be referred for colposcopy. What about benign endometrial cells present? So this is very different than having atypical glandular cells. So endometrial cells are reported in patients age 45 and over. Depending on their last menstrual period, things like that, you may expect these cells to be there. That's why it's important when you're entering your information for the PAP test to be done. It asks you about the patient's history, including their last menstrual period. We used to report age 40 and up, and that says under age 40. It should say under age 50. So between 40 and 45, there's very, very low risk of endometrial abnormality. between 45 and 50, there's about a 1 to 2% risk of endometrial abnormalities such as hyperplasia and malignancy. And raised age 50 and up, it starts to increase. The bottom line is if you see endometrial cells in a patient who's 45 and who's menstruating normally, maybe she was on her period at the time of PAP, that's expected. It doesn't need further workup. But if the patient has any risk factors, if the patient's over age 50, or if the patient's postmenopausal, endometrial cells would prompt you to perform an endometrial biopsy. And this is especially important in postmenopausal women, that they get that endometrial biopsy done, since those cells were seen on their PAP. Well, that's all I have for today for cervical cancer screening. Hopefully that is helpful to you. We appreciate everybody who's out there screening patients, educating them about HPV-related diseases, and then referring them in so that we can find any precancerous cells and treat them. And don't forget to recommend HPV vaccination to your patients. We know that these screening mechanisms are not perfect. They do a great job at finding disease, but they don't find all of them. And even when they come to us for colposcopy evaluation, we do dozens and dozens of these procedures every month. So we feel like our colposcopy evaluation is thorough and very accurate, but it still can miss disease. So the best way to prevent cervical cancer is through primary prevention with those HPV vaccinations. So encourage your patients and their family members to get vaccinated. And that's all I have for today. Thanks for your time.